coming on a middle evening on the middle of the week. What I would like to do today is, first of all, just tell you a little bit about my role here at the Mind Institute, since that's part, maybe not the most important, but part of the function of these talks is for you to get to know who's who and what are we doing. And I've been working on several different things, as Dr. Hales just mentioned. The longest standing area of research for me has been trying to define the nature of social attention disturbance in autism, and I've been doing that for quite a long period of time. Then I was working on inpatient units at UCLA where higher functioning children with autism were coming onto the inpatient units, usually not for autism, usually for a comorbid disorder. And I started to develop a real clinical interest in that group. And that's what I'm really going to be talking about today. And then part of my job here is to try to build a bridge between the Mind Institute, which is a very formidable entity in the UC system, and then also the School of Education at UC Davis to try to allow those two units to work together more productively in translating research to educational practice for children with autism. So basically, I'm going to talk about this second research area. And what I thought I'd do is I just sort of set the stage with some recent publications. Those of you who know who Tristram Smith is, he worked with Ivar Lovaas and is now one of the foremost people in the field in looking at trying to evaluate the effects of intensive behavioral intervention for young children with autism. He's at the University of Rochester. And he recently published a study along with his collaborator that indicated that if we went back to an old subtyping developed by Lorna Wing, in which we looked at whether children were aloof, passive, or active but odd, we could actually predict something about their outcome or the responsiveness to intervention. And that is children who are much more active, the active but odd children, have responded better to early intensive behavioral intervention. I'll show you a little bit of data on that in a second. Well, the same thing has been reported by Shearer and Schreiben. Using a completely different intervention approach, they also have reported that more active children, and in particular children who seem to approach others more readily, look like they're responding more quickly and more robustly to early intervention effects. Here's the data that Tris and his collaborators published. They basically were looking at a replication to some extent of part of the Lovaas approach to early intervention, but it's a little bit more sophisticated now. And they were able to classify children as aloof, passive, active but odd, and also they had a typically developing control sample there. And they used what is called, and I'll describe it later, the Wing schedule or system for classifying, the Wing subgroup questionnaire. And what they found is, if you can see that bottom part of the slide, and I hope it's large enough, is that first of all, one of the big messages here was there was no difference in initial IQ among these three groups: aloof, active but odd, passive. We had thought that it was tightly related to IQ, but it turns out increasingly studies are showing that it's not. But look at the responsiveness. Look at what happens in the current IQ scores, which is post-intervention. It was that active but odd group, even though they had the same IQs initially, that showed the biggest change. Then we have a report from one of the more prominent groups in the Infant SIBS network. And what they've found is if they use temperament measures and they classify children as being more involved in a behavioral approach, which really means that they're looking more at people, alternating gaze to people, but also approaching them with positive affect, that those children, that tends to discriminate the infant SIBS who go on to the diagnosis of autism, the SIBS who go on to the diagnosis of a spectrum disorder, and the SIBS who go on to no diagnosis whatsoever. And it's the one measure here that does that best. Even though IQ is very strong, this happens to be the best predictor of the separation in this study of about 54 to 60 infant SIBS of how they're going to end up diagnostically. Now, one of the things that this group says, and this is, Peter Satsmari, Lonnie Zwagenbaum, and others, is that they went back and they started to look at some of the work that we were doing on using a theory to predict individual differences, in which we were actually starting to talk about the basis of approach versus avoidance, activation versus inhibition in autism. And they said that their data really goes along well with what we were talking about. A little bit later on, I'll show you this data again, and I'll juxtapose it to some data we have on older, higher functioning children to make that case again. What Lonnie and others are finding in the SIB project goes along fairly well with some of the models that we're trying to develop to explain individual differences in course and responsiveness to treatment for children with autism. And one of the basic ones is that this has been around for a long time. One of the interesting things for me was back in the 80s when I started working on autism, there were like two different factions. One was saying that this social disturbance could be described as a pervasive lack of responsiveness to others. And then another, Lorna Wing, who was saying, what are you talking about? You can actually see 3 different response patterns in there. And that some children are highly responsive, they're active but odd. Some children are aloof, they're not responsive. And then there's a group in the middle, passive, who don't seem to do much unless you put them in a structured situation, and then they're highly responsive. So Lorna Wing, in 1979, was telling us that this whole notion of a pervasive disturbance in terms of social impairment was incorrect because she could see subtypes. And subsequently, many people have validated that subtyping. What's the basis for it? We're going to talk about that a little bit. Why would this be important to intervention effects, to children with autism? Well, the main idea here is that when you're learning and when you're in an intervention and you're going to respond to an intervention, if you can be constructivist in the intervention, you're going to do better. And that goes along with Vygotskian theory and Piagetian theory, and just too many theorists to really name, that learning is an active process, that you have to engage in an activity, or you learn best from actively engaging the environment. We learn best actually when we can actively engage the environment and change it, and learn from the changes that we do. But we can often learn from active engagement with somebody else that shows us how changes in the environment can give us information. But if you're active, you tend to learn more than you're passive in any learning situation. There's a large literature on that. And let me give you an example that I use from my joint attention work on why activity is so important. So when we learn language, and if any of you have heard me talk in the last 20 years, you've probably heard this before. When we learn language, right, we're not taught language word by word. We're not passive recipients of information. We are active as infants in organizing information so that we can learn from it. So parents typically provide infants with opportunities to learn words in incidental learning situations. They label an object. But the child might see 10 to 15 novel objects out there and not know how to associate this new word. So they look at the direction of gaze, and that helps them narrow down the field of the environment that might have the correct referential match, and that increases the likelihood that they're going to learn. So by actively seeking to organize the social information, the child increases their opportunity to learn. If, on the other hand, they actually show something to their parents, that's even more active. That's approaching. That's coming towards the parents and approaching them and saying, look at this. And they establish the optimal opportunity to learn something about that object, because that's where their attention is. So that's just one example of particularly early active tendencies that enhance learning. So what we're going to talk about today for the next 45 minutes or 40 minutes, something like that, is really higher functioning children. And I'm going to talk about the modifier model of autism. And the modifier model is one way to think about individual differences in autism. And I'm going to talk about 2 dimensions, this dimension of activation and inhibition, approach avoidance. I'm also going to talk about error monitoring, because those two seem to be very, very useful in thinking about individual differences in learning and responsiveness to intervention. And I'm going to present a variety of data on those two dimensions for you. Whoops. This is actually data that comes out of a lab that I left behind in Miami, funded by NIMH. A large study, relatively large, of high-functioning children with autism, about 100 children with autism between the ages of 8 and 16, and 100 controls, including children with elevations in ADHD symptomology and anxiety symptomology. The primary collaborator and co-PI here is Heather Henderson, and when I talk about ERN data, it's really her data. She's the expert in ERN. In fact, when I talk about asymmetry, she's the expert in asymmetry too. I'm not an EEG expert by any means, although I understand the value of using EEG as a biomarker of differences in children with autism. Let's just quickly make sure we're talking about the same group of children, talking about children without mental retardation when we talk about higher functioning children. They have a variety of social problems still, and they're very significant in their lives. They're just not affected by mental retardation. We don't know very much about these kids. The course is not clear, and it's probably changing with cohorts. We do know that it's a little bit difficult to use these terms, autism, high-functioning autism, and Asperger's. They confuse everybody. The reason I use high-functioning autism is there's a problem with the current diagnostic system. It's almost impossible, given DSM system or ICD system, to truly meet criteria for Asperger's disorder. Because if you meet criteria for Asperger's disorder, usually the qualitative impairment of social interaction or restricted and repetitive behaviors is expressed in impaired communication and repetitive or idiosyncratic speech. If you meet criteria for impaired conversation or communication and repetitive and idiosyncratic speech, automatically it's autism. So that's the reason I'm using high-functioning autism here. It's not to say that Asperger doesn't exist. It's to say that our diagnostic system does not allow us to use that very precisely. So get rid of that. Here's data on how many kids there are out there. And the estimates keep going up and down. I think the CDC is now saying 34%. But the CDC has also published studies that are showing 44%. This is just a sample of data from a number of epidemiological studies divided by, at 1998, there's studies that had IQ information in them. And what you can see when you compare these studies is that there's a big change in the proportion of children who we would call higher functioning children with autism since 1998. And it stands to reason. There's all sorts of reasons: ascertainment, better measurement. One reason is that we do a much better job with early intervention, and the thing that early intervention, the most frequently used marker of success in early intervention studies is changes of 10 to 15 points in IQ. It's not necessarily change completely in symptom presentation, it's changes in IQ. Some are beginning to argue that symptom presentation changes for many children as well, and that's a very difficult thing to definitively get at this point in time. One of the things for these higher functioning children is, though, their parents report more comorbid behavior problems with hyperactivity and attention problems, depression and anxiety, and the kids themselves report much higher rates of OCD, anxiety, and depression than comparison children do. So high-functioning kids are smart, and they're very complicated, like we all are, and trying to sort that out is pretty important if we're ever going to understand how to work effectively with those children. Just another way to show this is an older study. There's now a replication. Both studies are out of Yale. And it just gives you the sense that many of these higher functioning children are being treated for things other than autism. Their quality of life and their mental status and their adaptive function is often affected by another behavior problem, emotional problem, which makes research and treatment very difficult. You have to try to figure out What's due to autism, what's due to anxiety, what's due to attention problems, and what are you going to treat, anxiety, attention problems, or autism with these kids? The good news is that the higher functioning children change more in adolescence than children with lower IQs, which makes a lot of sense, but here's some data on that using the ADI, the Autism Diagnostic Inventory, and the scale scores there, and also the Vineland. You know, if you reduce your scores in the ADI, that's better, and you can see that all children in this relatively small study showed change on the ADI, positive change, fewer symptoms, but the higher functioning children change more. And there's several replications of this now. And one of the reasons for that, one of the reasons for that I want you to understand that change is occurring in these children in elementary school and high school is that's part of my job now, is to try to emphasize that we need to improve intervention at that level. And one of the arguments is that early intervention is really productive for kids with autism because it's at a time of neuroplasticity when intervention can have the most direct effect or the most powerful effect on reorganizing the nervous system. Well, that's probably true, but it's not true that there's no potential in terms of plasticity in elementary school and adolescence. This is a chart that's really for ADHD kids, but it's used to say, you know, the critical period for intervention for ADHD is between 6 and 18, because that's the point in time when the frontal lobes are really organizing, and a lot of frontal lobe functions are codifying and maturing. Well, it's the same case for kids with autism. That phenomenon, that neuroplasticity of the frontal system is there for them as well. And so intervention, continuous intervention, elementary through high school, has both a moral imperative, but probably a neurodevelopmental imperative as well. So in order to provide this intervention, though, we really have to understand why these kids are so different. And let me just take this down for a second. If we're going to talk about differences, let's just look quickly at a couple children and see their differences if we can.
Hello, I'm Karen Woodings. I have a 13-year-old son, Mickey, who was diagnosed on the autism spectrum.
Hello, my name is Mickey Woodings, or if you want to be really happy, you can call me MKW.
Oh, you like that. Mick processes information. It's fascinating to watch it, really, because you can speak to him and he'll understand you, but for him to truly process it and understand it and then act on it could be weeks later. So now, what makes you unique at school?
What makes me unique at school is that I like to use myself in the third person, and I often refer to myself by using my initials. I hope you aren't offended by that.
I'm not offended at all.
Maybe you.
Now, what makes you want to do that? Do you know?
You know, Mom, I am sorry, I do not know. I've done that for like a couple of years now, and I still haven't figured. And I haven't really given it much thought as to why.
He is a nice guy. He'll grow up to be a nice guy, but he'll be a very quirky guy, you know. And
okay, so I mean, I think that gives you a sense of one 13-year-old who's affected by the syndrome, and many of you already are aware of these individual differences. Still, it's useful to remind ourselves. Let's look at a 16-year-old.
My husband's name is Joe, and we're parents of an autistic 16-year-old teenager who is considered high functioning in today's world of autism. He's been a joy to our family, and it was tough in the beginning.
When I was a small child, I was biting people's fingers, I was pulling their hair, I banged my head against the wall, and I made very loud noises.
He's a very determined child. He's now in an honors classroom. He has a 96.2 average, and he's conquered getting his driver's permit, which is unheard of.
This year, one of my subjects is trigonometry, and I have some problems with it, but it's a little tricky. You have to learn back from algebra.
So two very different presentations. I mean, one was kind of an affable, giddy presentation. The other was much more serious and a little bit slower. The thing that the last young man that said that I want to make sure that we're all aware of is we can't tell which children are going to be high functioning early in life. You can have a child that is behaviorally out of control or seemingly not taking things in at all end up being high functioning, and another child who's clear from the get-go that they're relatively high functioning, and maybe even some that look high functioning and end up not so. We're not quite sure about that. But that's the problem for us at the moment. High functioning is not a course that's so easily identified early on, and we want to understand why. And maybe if we can understand a little bit more about individual differences, we might be able to improve prognostication with respect to higher functioning kids. And certainly that's one of the goals for some of the research that I'm going to talk to you about now. This is just a summary of basically this in some sense. When we think about individual differences in autism, we know that we're getting a much, much better picture of the complexities of etiology in the sense that we have on genetics, for example, often people are saying now 10 interacting genes. That's probably not accurate, it's probably more, but we have the sense of multiple etiological processes that combine ultimately into the syndrome. And therefore you can have different patterns of the etiological processes giving rise to differences in the taxon or the expression of the disorder. Taxon is Paul Meehl's term for the essence of a form of psychopathology. So certainly we can have sort of bottom-up processes giving rise to differences, and they're very critical. However, it's also the case that no form of psychopathology, developmental or otherwise, is expressed without being affected by the more general dimensions of individual differences in human beings. Temperament being one term that's used to describe those dimensions of individual differences. So then you have these modifier processes that have nothing necessarily to do with autism, but they're interacting with autism. And they're changing the expression of it. And if we can understand the interaction, there's two ways to understand this taxon, is to understand these etiological agents, but then understand the way in which these modifiers interact and change the expression of autism. That's what we're doing in the Miami project, is talking about the right-hand side of this individual difference model. Or at least we're trying to. So one of the things that I noted a long time ago, in 1995, was that when you looked at this passive, active, and odd, and aloof typology, there was theory in terms of general individual differences among people that seemed to relate to that. And it was proposed by Gray and then studied by Davidson that there are these two neural systems, behavioral activation, behavioral inhibition, and that they have relative balances in people. Some people have a tendency to be more active, gregarious, engaged with the environment. Some people tend to be more inhibited, withdrawn from the environment. The former group tend to show more positive affect, but more anger and conflict. The last group shows more negative affect. Behavioral activation is something that we don't necessarily associate with autism because the prototype is aloof. But in point of fact, it's quite possible for a child with autism to have a behavioral activation bias or a behavioral inhibition bias. And the way you can measure that is by looking at a simple measure of resting state frontal activity. Davidson, there's now, probably 150 papers or more showing that simply by taking the ratio of activity on the left frontal and right frontal hemisphere using EEG and creating a single term, you can type people as likely to be more BAS or behavioral activation oriented or biased or BIS oriented. So we decided, based on theory that we had developed in the 90s, to test that with older children. And the first study was published by Steve Sutton, who was a student of Richie Davidson, who I recruited to Miami to try to get this study done. And Steve was really expert. He had made some real strides in understanding EEG measurement of BAS and BIS. And we looked at a group of children, and just to help clarify, resting state EEG, if there's more activity on the left relative to right, it's indicative of behavioral activation. If there's more activity on the left rather than the right, it's indicative of a bias towards behavioral inhibition. There's a variety of studies now that begin to try to localize the systems involved. As you can see, they're pretty much motor systems, frontal systems, both dorsal anterior and ventral anterior, meaning that there's probably both a motor component, a self-initiation, and a motivation component, all tied together in behavioral activation and inhibition. So what Steve found was this, that we could type these kids exactly as we could type typical kids. There was no difference in the numbers of children who were typed as behaviorally active or behaviorally inhibited between autism and comparison samples, just as we expected. We didn't expect this to be specific to autism. We just expected it to vary in children with autism. And it wasn't related to IQ, which was good. What it was related to was symptom expression, though. And this is the ASSQ, which is one of the few really good measures of symptom presentation in high-functioning children. For example, when teachers use the ASSQ, if you give teachers the Conners and the ASSQ with samples of ADHD and high-functioning kids, they can't differentiate the ADHD and high-functioning kids on the Conners, but the ASSQ gives them a real strong capacity to see the differences between them. And so what we can see is both the left and the right frontal kids were way over criterion on this measure, and here's a typical group. But the left frontal kids, am I pointing to the right one? The left frontal kids had fewer symptoms, significantly fewer symptoms, which is exactly what we would have thought, because we thought the more active kids would at least appear to other people as less symptomatic. Wasn't sure whether they were less symptomatic, they simply would appear because it doesn't fit with the prototype of autism. So then, that was interesting. In the labs that I've been involved in, we typically try to replicate something 2 or 3 times because we're dealing with small samples. And so you have to see what maintains itself. And that's an important lesson for those of you who read research as a profession or those of you who are just trying to keep track. One study does not make a finding make. You have to see it replicated several times. So here's a study that's in submission by Courtney Burnett, who's at Vanderbilt now. A larger sample of children. And you can see that, just for those technical-minded people here, there's just no difference in the asymmetry numbers that we're getting, the alpha wave ratios that are giving rise to this measurement. And here we find that one of the main things was that it was related to, the asymmetry was again related to symptoms, but this time we had an indication that it was related to course. And that is that on the ADI you ask parents, when did you identify children with autism? This isn't the right slide, but when did you first suspect that children had symptoms of autism? And what we see is, let me just go on to a different slide. That's the one that I want to show you. Is what we see is that for right frontal and left frontal children, that the tendency was for the parents to say the right frontal children showed symptom presentation pretty early on, but not for the left frontal children. The left frontal children parents started to report that they were showing symptoms later on, and they also were way out here. So that the left frontal children were harder for parents to identify. Okay. Let me just go back here. We also started to look at different types of measures. The social responsiveness scale is a very well-developed quantitative measure of social symptoms. Probably better than simply using a symptom measurement because it's more sensitive to individual differences. And what we found was that left and right kids differed on a critical symptom component social cognition, and that's parents' reports of how well the child can anticipate the behaviors of others, think about the behaviors of others, respond to thoughts and desires in other people. So that was the second study that seemed to suggest to us that we were onto something here. Now, one of the really interesting things that I want to point out is, again, the left frontal children are being identified later, right, in this study. And in the infant siblings study, you see that the kids who are more active are less likely to be receiving the diagnosis. The infant siblings are less likely to receive the diagnosis of autism. For my money, that's coming close to what we want to test. We want to test now and see whether these left frontal, right frontal bias measures can tell us something about infant sibs or young children, their course. Maybe one of the things we're having difficulty doing in identifying young children is that we miss the high-functioning children, because symptomatically they're not so apparent. But if we can see a child who's coming close to a diagnosis who's left frontal, we might be more likely to say, oh, there's a strong potential that that's a high-functioning presentation. But we still need a little bit more research, so we've done a third study with the largest sample yet, and this is Annie Inge, who's was at NIMH and is now at Hopkins. And what she did was she said, well, look, none of this matters if the measurement isn't reliable. If we don't have test-retest stability here, people are going to say you can't use this measure with children with autism. And what Annie showed was that the test-retest reliability was exactly the same as it was for the typical children and exactly the same as we see in studies of adults. So this left and right frontal measurement shows, I think this is 6-week, test-retest reliability, suggesting it's indexing a stable component of processes that are related to behavior inclinations in children with autism, at least high-functioning children. That, by the way, if you're trying to come up with something that's useful for diagnostic subgroups or predicting or prognosis, you have to know that there's test-retest reliability, or you have to know something about the reliability in general, but specifically test-retest, because if there isn't adequate test-retest, your findings will bounce all over the place, but ultimately you know that it's not going to be clinically useful. If there's no test-retest, it's going to be hard for it to be clinically useful. What Annie also did was say, look, we're getting all this parent report data, and it's not telling us what we want it to tell us. We want to know if this tells us something about subgroups of high-functioning kids with autism. So she went into the literature and looked for the measures that were used to discriminate Asperger's disorder from high-functioning children. And she found a fair literature on the childhood communication checklist, which was developed in England. And basically, the childhood communication checklist is something where you can get objective measures of communication. And basically, one measure is of semantic and grammatic production. And the other is in terms of how well the child uses language in a socially functional way. And what we found was that the left frontal children did better on this measure, the grammatical and semantic, but they made more errors of execution than the right frontal children did. That pattern is the pattern that often has been associated with Asperger's disorder using this measure. And we think the rationale is like this. These left frontal kids have better language development, which is part and parcel of the Asperger's kind of child. But then they're very active with it. And because they're so active with it, they produce more errors in functional language use. Whereas these kids are hesitant, they're inhibited. They don't use the language, they have a lot, but they don't use it as much. So they produce fewer of these pragmatic errors. So this study now begins to move us a little bit closer to saying that maybe this activation-inhibition dimension is part of what we've been responding to when clinically we say, oh, there's differences here, and we've labeled them Asperger's and high-functioning children with autism. And then again, we looked at parent retrospective report, and the way research is, we didn't find the same pattern of results. We didn't get it on the same item. We got a different item giving us the difference, but it is an item that's conceptually similar. Here it's, when did you think clear symptoms were present? And you can see that parents of the left frontal kids report a sort of combination of clearly autistic symptoms or clearly symptoms of a problem, but not specifically autism, whereas parents of right frontal children said clearly symptoms of autism were present. So again, it's just a difference in the clarity with which we can see autism in different children, we think. So we now have this EEG measurement system that lets us look at behavioral activation and inhibition. It's an important axis of individual differences in all people, and it looks like it's a reliable and valid marker in kids with autism. It looks like it's related to, conceptually at least, a long-standing subtyping that Lorna Wing proposed. We believe that these differences do two things. One, it changes the way in which we might see symptom expression in these children. It's more difficult to see classic symptom expression in the active children. But in terms of their responsiveness to intervention, they're probably more constructive as children, more likely to engage in a learning environment, more likely to benefit from it, tend to show more rapid intervention response. And so we think that this is a really pretty important area to push further on now, that it stood the test that we have of 3 preliminary studies that give consistent data and intriguing findings. So we want to push forward, and we have an Autism Speaks grant in to actually test this now. Use this measure and provide intervention to children, and use the measure to predict intervention responsiveness. The other dimension I want to talk to you about is also tied up with learning, because learning is critical for these kids. They don't learn the same way or at the same rate that other children do, and if we can understand that, we can improve intervention. So one of the things that we've been, in my group working on joint attention, have been thinking about is what are the neural underpinnings of joint attention process? And so one of the things that I published a few years ago was the notion that the critical component of social attention disturbance in autism is a difficulty in initiating sharing of experience or shared attention with other people. And that's probably got a motivational component, we were just talking about that, but probably also a self-monitoring component. So in this paper, I went into the literature and I figured, okay, if it's self-monitoring, how are we going to measure that? What are the models of the neural systems involved in self-monitoring, and what are the measures? And one of the measures is error-related negativity. So we did it, and Heather Henderson was working with Nathan Fox, and she was publishing data on the relationship between error-related negativity, and I'll tell you what that is in a second, and shyness in children. So I thought, oh gosh, I mean, if she's relating it to shyness, it probably does make some sense to bring it into work on autism. So how do we measure this? Again, it's an EEG measure, but this time it's one that's called a evoked response potential. It's locked to a particular type of response. And here's the paradigm. It's called the Erickson flanker task, and it's really easy. And you can make it into all sorts of different things. You have these arrows, and you have to simply say which way the central arrow is going. And you can make it slightly harder by having the flankers go in the opposite direction. And you give people 200, 500 trials, and occasionally they make errors. And you're measuring EEG, and when they make an error, you can time lock the EEG so you can see how the brain reacts to an error. And what happens is, in a particular band of EEG, you get this negativity, this polarization of indicating activity. And the more negative it is, the more reactive you've been to the error. And if you notice, this is being measured at 50 to 80 milliseconds after the error. It's before we can even tell the kids you've made an error. It's a very, very rapid response to error. Your brain is monitoring your goals and your behavior towards those goals. And when behavior doesn't meet goals, there's a trigger to say, oh, that was a problem. I've got to now change my behavior in order to bring it in line with goal-directed action. And the area of the brain is this really central both in terms of brain morphology or architecture, but also central in how we understand attention regulation, the anterior cingulate. And there's a lot of data. One of the advantages of using this ERN paradigm is there's lots of information about it. So what did we find? We found that there was a group of children with autism tended to show very elevated or very high amplitude ERN, strong reactions to error, and very shallow or poor reactions to error, and that covaried with IQ a little bit. But when we took IQ, when we parsed the variance of IQ out, even with that, we saw that ERN was related to symptom presentation. Stronger response to errors, lower or better symptom presentation for high-functioning children with autism. So that was the first study. Heather published that in 2006. We've now gone on to 2 or 3 additional studies. What we now see is that there's probably a change in ERN functions across age for these children, with stronger responses to error for younger children, and then a shift to less responsive for older children compared to controls. But more importantly, we see that ERN, along with other measures, is relating to parents' overall, and this is a very good measure, convergent measure of social adaptive skills. That ERN is relating to that, and the stronger the ERN, the better off kids are in terms of social adaptive behaviors, according to parents. So then we began to say, well, is this related to specific areas of social behavior, like face processing? I dare say there are probably more face processing studies underway on autism in terms of trying to define the nature of the social deficit than most other paradigms. There might be 1 or 2 that are comparable. Most often they say that the problems for children with autism in face processing are related to areas that are specific in the brain for developing expertise in face processing. But what we find, an undergraduate student developed this paradigm. We slowly reveal faces, and we ask kids to push a button when they think they know what the expression is. And we can reveal the eyes first or the mouth first, and the faces can be upright or upside down. This, by the way, she developed this for her master's thesis using PowerPoint, high technology, but it worked. It's very, very good. And we measured how quickly children could recognize the face, and also whether they would correct how certain they were of the facial recognition. And basically, the first thing we did was say, is this paradigm giving us information similar to other face processing paradigms? And it does. Kids with autism are more accurate than controls on those upside-down faces. They can identify upside-down faces better than typical controls, but they don't do so well when the faces are upright. And that's exactly what we saw here. So that validated the paradigm for us. It's telling that we're getting basically what we should be getting. For both groups, though, for typical kids and for kids with autism, stronger ERN signatures was related to better processing. Those kids can detect errors better, and part of that error detection helps them process faces. This is a generic learning system that we're talking about. The fact that we're seeing it in both groups emphasizes that. It's not specific to autism, but it's pretty important in terms of individual differences in autism. So then we asked the next question, which was, okay, well, we can do this with arrows, but what happens if we do it with faces? What happens when we present kids with errors in face processing? And so instead of the arrows, now we've got tell us whether the mouth is up or down, by hitting a button, and we can either make the flankers comparable or not, congruent or incongruent with that. And so we had the 2 conditions. Now kids are getting 2 measures. And what did we found some pretty interesting things. First of all, like ADHD children with autism do not slow down as much after errors as typical controls. In fact, they actually speed up a little bit, which is a problem. You don't want to speed up after errors. You want to slow down, because when error is telling you that the way you've approached the problem is wrong, slow down and see if you can correct that. But the most important thing was that whether or not children actually, they can speed up and get it wrong, or they can speed up and get it right. So we looked at speeding, we looked at anything that was right. How well did they correct themselves? And what we found was that children with autism reliably corrected themselves after an error on the arrow flanker, but not on the face flanker. Typical controls did both. So for some reason, the kids with autism, they were showing a difference in the tendency to correct. And then we found the following. We found that children who responded more quickly and didn't correct on social flankers displayed lower peer-related skills. Now, what Heather's done, she's imported her shyness paradigms into measurement of high-functioning children with autism. So we have these high-functioning kids come in, sit down with peers, and we actually do quantitative analysis of their peer interactions. And what she's finding now is that social flanker is giving us information that's directly related to how they interact with peers, particularly eye contact, and also that those kids are reporting greater internalizing problems. But that wasn't true. And here's a comparison between the type of correlation that we see with the face task and the arrow task. Probably not a significant difference in the correlation, but the samples would need to be a lot bigger to test that. And this is just an example of this large social skills factor measurement that we use, and correction following error on faces. And you can see that it's, high-functioning kids just are much better off socially when they're correcting rather than when they're not. And then finally, to give a little time for discussion, I've talked about these two dimensions, and they're not completely separable. And for those of you who know these dimensions, they're not completely separable. They're kind of intertwined. But we wanted to begin to understand whether, if we combine them, they tell us even more about problematic behavior for children with high-functioning children with autism. And here, this is very preliminary data because we really need to push the sample size. But the group that was worst off symptomatically were the children with the least amount of response, ERN, in terms of error monitoring, and the right frontal children. They stood out as being the most symptomatic group in terms of autism symptoms compared to these other three groups, but you'll notice that cell's too low. So this is the next direction that we'll go in, is can we combine these to really begin to see some sort of indication about differences that hold together when we use both measures. So what I wanted to do is give you an example of how we are taking a slightly different approach to this issue of individual differences. We started out with some understanding of an old subtyping. We began to see that subtyping was related to treatment effects. At the same time, we were doing research on the nature of that active but odd and aloof subtyping, and that started to come together to suggest that EEG measures of behavioral activation and inhibition may be important in terms of understanding differences and understanding course of autism. The good thing about those measures is that Nathan Fox and Richie Davidson have used them effectively with 10-month-olds. So we know that we can probably get in there by 12 months at the latest to begin to get some sort of stable measurements with kids. And then we've started to use error-related negativity because of its relationships to theory on social attention. And that's also telling us something, that children with autism differ in how well they can monitor errors, and that has meaning with respect to social behaviors and social information processing. Thanks. Sure, questions would be fine.
Given that the right frontal effect is associated with the active but odd personality, which also is the type that parents are more likely to report at an earlier age symptoms, is there any thought that the reason the active but odd has a better outcome is because of earlier diagnosis and therefore more likely to receive early intervention?
Well, let me just make it clear. It's actually the opposite of that. It's left frontal children who are active but odd, and they're identified later. And we think that they actually have the better outcomes. So we're pretty sure it's not because of early identification, because this thought is that at least some portion of those children aren't getting identified until 40 months of age. But we're not completely sure until we actually go in with that measurement and see what's happening in a sample. This is retrospective at this point in time.
Just from an educational point of view, is the idea that they've noticed that the right frontal, I mean, it's not really quantitative yet, but like, is the idea to be able to identify if they're more left frontal or right frontal, so that in the future, maybe since the right frontal don't have as well of a, the early intervention doesn't seem to help them as much because they don't participate. Is there an idea to kind of approach their early intervention differently when they're less likely to engage themselves actively in a normal setting, educational setting? Is that kind of the goal?
Yeah, well, that's a big leap. We're not sure whether the right frontal kids aren't active enough in early intervention, but it's a possibility. If we can show that, then the next step would be to say, okay, so why aren't they active, and can we change that? In point of fact, though, when you listen to people who've been doing intervention for a long time, like the Kegels or others, a main point of early intervention is to try to get kids to be more active. We've been trying to do that for a long time in early intervention, and there are some kids who are less responsive to those attempts than others. If we can identify those kids beforehand, we already have a group of interventions that work for the active kids. We can continue to do that, but now we can actually say, oh, this child's is going to be less likely to respond to these interventions, so now we have to develop different interventions for this child. So that's about as far as it goes. It just helps us say, there's a group here, we need to understand them better because our interventions aren't targeting them well. So just to pull that up to the high-functioning kids, though, sometimes we use group interventions, sometimes we use individual interventions. There's some rationale that the more active child is going to do better in the group interventions, and the less active, more inhibited child might do better in more individualized interventions, at least as a slightly different distribution for presentation to those kids. The same thing, and I should have mentioned this before, for ERN, we often use cognitive behavioral interventions for children with autism. In order for those to work, you have to be able to monitor your errors. So we're fairly sure, and we need to test this, but it makes sense that the kids who with higher ERN may respond to cognitive behavioral methods better, whereas the kids with more shallow ERN may need to have a pre-intervention on response monitoring before moving into cognitive behavioral therapy. Okay.
With that ERN, is there indication that those who have a better ERN have increased anxiety because they recognize the challenges, so that the high-functioning individuals are likely to have more anxiety and possibly more aggression based on their frustration?
Well, we do know that higher ERN is related to OCD and anxiety, and we thought that was going to be the case in the studies with children with autism, but so far we've seen it in one study, but not two. So for some reason that doesn't seem to be holding, and in point of fact, there's some really interesting work, and we're trying to do some of it on serotonin transporter, and the way the serotonin transporter seems to work in terms of anxiety and issues like that may be the opposite in bipolar, and it may also be pretty different in high-functioning kids with autism. But that's exactly the right expectation. It just hasn't been borne out by the data yet.
Yeah, how much monitoring self-errors is predictive of monitoring others, like joint attention or more sophisticated social abilities?
We don't know. I mean, that's a really fundamental question. Does that relate to the capacity to monitor more than one thing at a time, for example? And if so, does that then relate to some of these more complicated social attention demands that we have in social interaction? We don't know. Hopefully we can get to it. Maybe you, with your experimental abilities, can really get at something like that, because it is a critical question.
going back to that question, and you mentioned multiple factors being responsible for joint attention. Is there any thought of that one of those many factors may have to do with neuromuscular inabilities to control eye movement and fine motor skills?
Absolutely. I mean, I think that the model that we have, I mean, this is taking us on a sidestep, but the model of joint attention that we now have is really has a strong ocular motor component in it. So anything that would disturb ocular motor control early on in life or change its biases could potentially have an impact. So Duchenne muscular dystrophy is a perfect place to begin to test that, and I've started to talk to people about that because those kids don't make a lot of eye contact, and we don't know how that's affecting their joint attention development. It's a very, very good question. Great. Well, thank you very much.
The UC Davis Mind Institute began in 1998 with a promise to find cures for neurodevelopmental disorders. Every day, our physicians and researchers come closer to fulfilling that promise. Their groundbreaking research on autism, Fragile X syndrome, learning disabilities, and other brain disorders is helping children achieve their fullest potential. Please call or visit our website to find out more about current studies, our research team, and upcoming events.